everyone, and thank you so much. So my proposal will be looking at screening for early life adversities among breast cancer survivors in primary care. So just for a little introduction and some background, screening for early life adversities, so factors like abuse, neglect, household dysfunction, even neighborhood violence that are experienced before 18 years of age, as well as social determinants of health among adults, is not incorporated in current healthcare delivery models. We know that more than 60% of adults in the US report at least one type of early life adversity, and 16% have experienced 4 or more adversities over their lifetime. Early life adversities can lessen an individual's capacity to cope as well as manage their health, or they have poor health management, especially when they have complex or multiple chronic conditions, so factors like cancer and cardiometabolic diseases together. And this includes poor medication adherence, which are critical in chronic disease biometric control. Clinicians are often unaware of their patients' early life adversities history, or ill-equipped or undertrained, with also having a lack of standardized tools to elicit clinically relevant information about early life adversities. Now, this has resulted in inconsistent early life adversity-related communication between patients and their providers in the primary care setting, also a lack of early life adversity-specific documentation in electronic health records, or EHR, as well as missed opportunities for early intervention and adverse health outcomes. So with adequate screening and risk assessment tools, primary care clinicians can help mitigate the negative effects of early life adversities by identifying at-risk individuals and families needing support. Still, we know very little about clinicians' early life adversity knowledge, their training, screening practices, and perceived intervention barriers in adult patients with complex chronic conditions, or the level of communication between the patient and providers regarding early life adversities. So understanding this relationship between early life adversities and adherence to chronic disease management among patients from diverse backgrounds, as well as social contexts, has not been previously studied. Furthermore, really trying to understand these relationships may be critical for identifying and managing the effect of early life adversity on patients with a history of cancer and cardiometabolic disease to increase treatment adherence, greater treatment success, and long-term quality of life. So the purpose of this research is to generate evidence and implementation strategy to support the use of digital questionnaires to increase screening for early life adversities and social determinants of health in primary care. Additionally, I believe this research will leverage the feasibility, timeliness, and cost efficiency of artificial intelligence and machine learning-based algorithms in cancer survivorship care to advance our understanding of the health and clinical care of patients who suffer from various adversities. And I hypothesize that the increasing screening for early life adversities and social determinants of health will connect more patients with resources, as well as support reimbursement for practices. So this project has 3 aims, and it's really nested within an existing NCI R01, focusing on adapting and implementing evidence-based breast cancer follow-up in primary care. So first, I seek to investigate factors that influence how primary care providers and female breast cancer survivor patients communicate about early life adversities in a primary care setting using survey tools. Next, I want to understand the primary care providers' perceptions about their ability to communicate with breast cancer survivors about early life adversities during routine primary care visits, and this will be done using depth interviews. And then finally, I seek to assess the capacity of primary care practices using structured electronic health record systems to implement full-scale early life adversity data collection through mapping existing resources and implementation using machine learning techniques. So this proposed research is innovative in a few key ways. First, it comprehensively focuses on primary care delivery to cancer survivors and addresses the lack of adversity and trauma-informed care and connection to community resources as a care continuum in cancer survivorship. The research will also assess the feasibility for primary care settings to use a digitized adversity screening questionnaire and increase revenue through supporting patients with trauma screening. And then finally, findings from this research could really inform other medical systems and patient populations burdened by the impact of unaddressed early life adversity on chronic health management. Thank you very much.
Fantastic. Awesome. Thank you so much, Ayana. That was wonderful. So I'm going to go to our panelists now, who have likely been noting and taking questions or thinking about questions for you, and can't wait to get into that. So I'm going to start with Winston and see what questions do you have for Ayana?
Great job, Ayana. No, I really like all the ideas that you tried, that you wove together in your proposal. I have a couple questions. One is about the use of AI ML in the proposal. And one thing I would just mention is, I don't think you have to use AI ML just for the sake of using it. So if there's a better method that you could use other than AI ML, I think that's totally appropriate. I don't think you have to sort of, but maybe you could talk more about how you were thinking about using AI ML in this project.
Absolutely. So I think the preface or disclaimer here is that I'm hoping to use this project in a training award, so a K grant. So the big training piece for me is the machine learning AI component. And so what we kind of had, so I'm currently working with our own team that I started to build this question out of, and we were interested in collecting information from the electronic health records in terms of breast cancer survivorship care and measurements for that. And along with some of the challenges of just getting information for those questions, we also know that there are forms available. So we use Epic in our health system, Robert Johnson Barnabas Health, and there are forms available there, but they aren't either turned on or being actively used. So there's a lot of missing data. And we also know some of these pieces are just actively written in clinician notes. So being able to use tools like machine learning and AI could help to identify probably where some of those communications are happening, how they're being accessed into the EHR system, and how we can try to pull it out with some of these approaches.
Yeah, that helps out a lot. So I think that if you're going to use AI ML, I think I would tie it to a rationale. What is the purpose of using it for this specific task? And I hear a couple things. One is the unstructured notes, one is the missingness of the data. And so those are the types of arguments I would make for why you need to incorporate AI ML. Sometimes you read through a proposal and people just throw in AI ML because they think that's what reviewers want to see. But I think there needs to be some type of justification that this is the right method to answer this specific question.
Great, thank you.
Great point. Thank you, Winston. I'll just move on down. And Yoon, any questions?
Sure.
Ayana?
Ayana, wanted to ask you a more specific question. What are the outcomes are you measuring?
Yeah, so it's provider perception, patient and provider perception. So in the survey assessment, they'll be getting at some quantitative measurements on perceived barriers and areas that patients have with challenges with communicating to their provider, and then also the provider being able to ask those questions or even having a available system to even kind of like flag or make available to start asking those questions, or even if it's asked and assessed prior to the patient coming to the visit. So along those lines, maybe even personal factors, like so clinicians having their own history of early life adversities might be a challenge for them, even bringing it up with their patients in that setting. So those are some examples. And then for the qualitative piece, those are, we'll also be building on and fleshing those out a little bit more in a subset of patients and the providers to really understand some of those barriers and where they see maybe some possible areas to work on and intervene on, but maybe that they see more challenging and how we could think about approaching them a little bit better.
It's on, great. So in the spirit of nurturing, and we're all a community trying to move this forward together, I'm going to open with a comment and then come to a question.
Sure.
Okay, so the comment is related to something Winston said about using ML, just throw it in there because it's cool, one option. Another thing, and I think that I've got a colleague who had an example like this that you may see in your work. She was looking for signs of intimate partner violence using an app to survey people at postpartum visits. And they had a big set of data that they had collected, and they used a machine learning approach to evaluate that data as they were thinking about next steps. And what it ended up telling them was that people wouldn't answer the question about intimate partner violence. It was a frightening question. They would leave it blank. But there were some associated questions in the data that correlated with a high likelihood of intimate partner violence on follow-up. And so there are times when the machine learning methods can be tools that help us look at complex data, even if they're not part of the core engine. So keep that in mind. And you may see something like that also because these events, maybe people don't want to talk about. You know, how bad was your childhood,
Yeah.
right? Anyway, so that was just a comment, and you know, thinking about how we can integrate ML in things. I'll connect you with her, by the way. Then the question I had was, you're focused on women who are breast cancer survivors because of the setting.
Yes, leveraging.
If you had your druthers, and when you write your next big R1 of your own, what area or what population might you start focusing tools like this, the early childhood events, on?
Sure, I think it's and first I want to say thank you for those comments, and I really appreciate them because I think what you said exactly, and pretty much why I don't call this just adverse childhood experiences, because I think adversities are much broader, wider than what's going on just in the household and parental maladjustment. I bring up neighborhood factors, discrimination, racism, all those things that also look differently in different populations. So I think it's very important to think about widely the different kinds of items that we can include in these measures of adversity. But to your question, I think I'd ideally like to just see this in a broader general primary care setting. So this could be the young adults who are just starting to go and go take care of their health on their own. Mom and dad are not taking them to the pediatrician anymore. Now they have to go follow up, and this might be the first time they hear they have hypertension or pre-diabetes or anything like that. So how do we make these questions available to them, especially at that younger age when maybe they do remember those adversities a little bit better, or maybe it's still a little new and raw to them. Definitely for folks in the midlife, as their health might be changing and they're getting different recommendations from their providers on how to either maintain a healthy lifestyle or make improvements before something goes on to more chronic conditions. So thinking about that retrospectively collecting of our adversities over the life so they can understand what are some of the potential barriers to that person maybe adhering to their medication or a lifestyle change that maybe was probably even brought on from that history of stress and adversity. So some of those areas. And then obviously can't leave out our older population because they still count too, and you guys can help me think about the potential applications there.
Thank you. Trin.
All right.
Yeah.
First of all, I have a comment and then I'll follow up with a question as well. I like your approach there.
Yeah, we're all in this together.
First of all, that was really amazing. So I work in a community setting where we have a lot of folks that are underserved and marginalized as well. So I really appreciate this project, and I think we actually had a discussion. So I work in a community setting where we work with resident folks that actually live in the community. We talk to them about feedback, what's going on, and this topic actually came up just last month about patient care provider. Oftentimes when you go in and see a doctor, you're not seeing a doctor for more than 5 minutes. You're seeing nurses and doing all the pre-check, and then you might be lucky you see a doctor for 5 minutes. So there's a lot of mistrust there.
Yeah.
Oftentimes I get doctors are very busy and they have a lot of things, but they're not being seen by their actual care provider, seen by physician's assistants or nurses or whoever it may be to actually do all the lab work, blood work, and then you might see a doctor for a few minutes.
Yeah.
So my question is actually, I'm just trying to make sure, how will this healthcare team ensure that the screening process is trauma-informed, like you mentioned, and minimize the potential of creating trauma based on your questions, because some of these things are very sensitive, and if there's a mistrust, they're not going to be able to answer those questions fully.
Absolutely. So there are several ways that folks can provide this information. So there is communicating with the clinician verbally, written, which I think the survey is really important because there is a lot of stigma here. There's a lot of underreporting in terms of adversities. So what you're seeing is really tip of the iceberg kind of things, especially, and that varies by gender. That varies by a lot of different factors. And so I think verbal, written, and being able to use a systematic approach like the HR, being able to get it plugged in that way so that, one, we don't burden the already busy clinical system by having someone document a check mark on a piece of paper and have to plug it in somewhere that probably won't get there for several months. But if it can be digitized and processed quickly, then what I'm hoping that I could use machine learning to do is also to be able to do risk assessment. So we could take that information, not again just on 10 items, but for several, and hopefully not burdening them too much even to answer all those questions, but to give us a better picture of who the potential what the potential profiles of early life adversity look like, and then based on those responses that they provide, we can provide resources. And so that's where the clinic can collaborate, either at the clinic level, the state level, whatnot, providing other avenues for patients to get services and contacts for places that they feel safe and less vulnerable given their experiences.
Wonderful. Thank you so much, Ayana.
Thank you
Everyone,
all.
please join me in thanking Ayana once again.
Good afternoon to everyone. And for this presentation, I majorly to prepare my O3 grant, and in this proposal, I try to try to develop the new the method to resolve some of the questions in primary care. So as we know, mammography is the most commonly used breast cancer screening imaging modality, and is increasing use to predict breast cancer risk. And mammography is a highly useful examination to track the longitudinal change of the breast density. So, and the breast density is measured from the mammograms, which entails application of X-ray energy. So the mammography machine has at its disposal instrument settings to fine-tune radiation dose. And since 2000 year 2000, these image settings are stored in digital imaging and communication in machine DICOM files of each mammogram. And in our recent primary study, we find that the instrument image parameter has been used to control the regression model for predicting the breast density. And the breast density estimate from the regression model was more sensitive to detect the intervention effects of the soy isopharmone on breast density in double-blind RCT samples. However, the regression model derived the estimate breast density is still not as sensitive as the breast density estimate from the MRI. And the reason is the MRI apply an identical image parameter to all women regardless of their breast density, and is considered as a gold standard for a breast density measure. However, the cost of the MRI prohibits it to be used as a routine screening tool for the tracking change. So in this proposal, we aim to develop statistical models to enhance understanding about the relationship between the subject's background characteristics and the persisting treatment and or the intervention regimen, and the instrument measure parameter from the mammogram, and try to understand the association of this covariate and the distribution of the breast density change using the mammogram. So, this is my first aim. So we want to use the AI as the first stage and to find the sum of the covariate, the sum of the relationship between the covariate. And then next, the second layer, we will apply the complex statistical model to do some prediction on the breast density change. And on our second aim, we also want to focus on the refining the imputation for the longitudinal research with the potential loss of follow-up. Because as we know, the longitudinal data set usually have the missing data, and it may have the impact the preference of the statistical model. So this is our second stage. And in this one, we will do a lot of simulation to compare a couple of different methods within the AI and the machine learning approach, and as well as the traditional statistical modeling. And in my part, I want to develop two-stage, imputation procedure. So that will be combined the ML and the statistical modeling. Hopefully, we can enhance we can reduce the bias and the inaccurate on the imputation. So upon the successful completion of this project, the AI-derived statistical models are expected to be a part of the DICOM files for future risk estimate. So it may be utilized by the clinician provider to further refine the monitor of the breast density change on mammograms and to develop the preventive strategies on the occurrence of the breast cancer. So overall, the impact is to improve the early detection and investigate useful prevention strategy. And to meet of this need, I'm still looking for the collaboration with the clinician and the AI expert and the epidemiologists or researchers emphasized in public health in my grant proposal. So it's all my presentation today.
Thank you, Naiwei. Thank you so much. Thank you. All right, and so we'll go to our panelists again for comments and questions. Trin, I'm going to start with you this time, if that's okay.
Sure.
Awesome.
Thank you, Naiwei. That was really great. Again, I think what you're doing is really innovative. I don't know nothing about mammogram. I have siblings and I have sisters. I think they're getting to that age to do that. So I think that's really cool that we're advancing that area. I think what the other doctor alluded to, there could be some potential threat they mentioned with AI. My fears, what are some potential challenges or limitations that you potentially see with this model for measuring the density analysis? And then could there be some false negative in this test?
I think the challenge is, because right now I want to use the two existing data set, and they do already have the density, breast density measures by the radiologist. So in my proposal, I'm not going to the the prior stage, try to apply the AI to get the estimate. But however, I want to borrow the estimate information and to refine the statistical model on the prediction. Yeah.
Thank you so much, Naiwei. John.
I can come back and have another turn if I only get one now here. But let's see. So one of the things you talk about here is a change in breast density as an additional risk factor for breast cancer. Can you elaborate a little bit more on that? How significant of a risk is it, or I'm not familiar with that.
Because this idea was from my previous collaboration with one of the nutrition, and based on my knowledge from her, she mentioned when because she's studying the intervention effects of the soy isoform. So she think the breast density change over time it may be a good potential risk factor to predict the occurrence of the breast cancer, because they want to understand the proportion between the fatty and the granular tissues, yeah, and that will affect how they associate with the breast cancer.
So that's kind of a hypothesis from some other research at this stage. Okay.
Yeah.
I can do more if there's time.
Oh, sure.
Go ahead, Yoon.
Thank you. I really appreciate how innovative your proposal is. I have a question regarding your current data set. Or is a pretty diverse patient population? Are you incorporating that into your interpretation machine learning process?
Okay, so I will in this. they do not use the same machine, then we may lose some of the primary information. Yeah, so we try to make a balance. Thank you so much.
Thank you so much, Naiwei, and thank you to our panelists. Great insights and comments.
Thank you.
Join me in congratulating Naiwei. Thank you.
So for you to remember what NLP, natural language processing, is, I had a couple of years of very hard time when I was 18 deciding whether I pursue applied mathematics or humanities, because I love them both equally. But what happened at the end, I married up the two. So I will have 4 main sections that I talk about. First, aims of my research, and then I talk about a system called eConsult. And then I talk about some machine language algorithms, tools that I would use for satisfying my aims. And I end up with business case of why all this is worthwhile. So the aims are to detect dementia case, and not only that, we want to be able to predict at what stage the patient is, and also we want to provide explainability, which is a hot topic in AI, especially in medical domain. We always receive the request, thank you very much for prediction, but why are you predicting what you're predicting is important. eConsult is a system through which primary care providers submit patient questions to specialists, and then they get answers. And usually this takes about 4 to 5 days before they are satisfied with the answer and they close the case. So the point of the eConsult is basically take away the edge from the system so that the patient don't have to necessarily wait in the lineup to see the specialist. And also for some patients, it would be difficult to commute. So this is a couple of main important purposes of eConsult. But the eConsult communications are text, so it's a fabulous test, but for me to try natural language processing for predictions. How do I do this? High level. I use graph representations because the semantics in natural language is captured by frequency and the context. But the alternative ways is what we represent as graphs. So you can imagine name entities being nodes and verbs being the relations or edges between those nodes. So you construct a knowledge graph off of the text. And that's the graph representation. Then you can use this as a training material so that what we refer to as graph neural networks, so that you can do classifications on the graph, you can predict the edges and nodes and so forth. So that's my area of interest, that the tool that I use to do predictions I apply in dementia. I also use what is called sequence prediction, so event temporal sequence prediction. So I use that very same graph representations to decide at what stage is the patient. And ultimately, I want to extend this, generalize it for other diseases, but each one has their own specific attributes. So the graph representation, graph neural networks, temporal sequence modeling are the 3 areas in machine learning. And also I obviously use language models for the explainability, completely independent experimentation, so that we can present what are the important features associated with each segment. For example, dementia case in contrast with non-dementia. So what is the business case of all this? You have to consider the process. So through the eConsult, when the PCP inputs the patient case, then the machine learning AI component would mention the odds of this case being a dementia case. If it is a black and white, we are certain it's dementia and no, so you can do a referral or not. But if the score is within the threshold that is a fuzzy borderline, then the explainability comes into the scene, so that the machine can inform the PCP what type of questions they have to ask to make the process more efficient, so that we are hoping that the AI component wouldn't replace the specialist, but shorten the iterations that otherwise would have to go between the two. So this would be helpful to refine the questions. Thank you.
Thank you, Arya. Thank you so much. All right, so we'll go to our panelists now. And Yoon, I'll go ahead and start with you.
Yeah, I think dementia is such a great case to use language processing methodology to tackle. So you mentioned about when it's ambiguous in terms of whether that patient fits into the referral criteria or not. That goes back to the PCP. Is that application of this tool at the point of care, or is it it's a little delayed, how you're proposing to build the model?
I think it would be at the point of care.
Okay.
But the scope of the initial phase is to prove the feasibility of AI. But I understand that I'm making assumptions whether even the PCP would like this or not, or it would be useful to them. Through the follow-up phases, we need to do surveys to get the first-hand and co-design and participatory analysis to hear what the PCPs have to say. Did I answer?
Yes, thank you.
Thank you, and thank you, Arya. And Trin, I'll let you go next.
Okay. I'm going to cheat. I'm going to say this is a two-part question. That's how you get two questions.
Yeah, that's how you get 2 questions. That's right.
So you mentioned these granular sequence in events. Like, is it always the same in patient, like I guess the pattern or sequence? That's question number one. And then number two is, I know dementia is kind of a broad term, just describes cognitive impairment, but to me, different stages and different progressions of dementia can vary depending on the specific types of dementia. Will this narrative or this process be able to predict the types of dementia as well?
That's the intention.
Okay.
And the answer to your first question is also fuzzy, because we think that we want to personalize it, so person to person would be different. Right. But in general, we are hypothesizing that there are some general stages that are applicable to everybody. But as a byproduct of this experimentation, we always refine the definition. So what does dementia mean at the end of the day is important. So it's kind of a chicken and egg. So explainability is also helping to better understand what we mean by dementia, because human has a perception, but then when we do the language models to extract the latent patterns, we see that they are different. So it's very informative to see perhaps wound-related or infarcture or skin lesion has to do with dementia cases. So these are insightful byproduct of our experimentations.
Thank you so much. That's great. I'll go to Winston next.
Can you give us an example of the type of e-consult that you're thinking about from the physician to the neurologist? Would it be somebody who you're concerned about dementia in? Is that right?
Yes, medicine is not my background, but I can think of a skin lesion case that I remember looking through the cases that the PCP is basically asking a very trivial question about the skin lesion that patient is facing, which prescription do I use, and what kind of test do we apply in this case, and then submit to the specialist, and specialist says, this is good, just give them this cream, and then have them visit back in 3 weeks. So it's kind of a gist of the conversation. But imagine from the knowledge translation point of view, as soon as the PCP puts the question before submitting it, a system would say, oh, by the way, the odds of this case being a dementia case is 70%.
I see. Okay. I love the idea of using unstructured data, and I think a lot of the data in our EHRs is unstructured, and that's often the richest part of the record. So I think that's like a really fruitful area to investigate, and I think very useful. I would consider expanding your sample from the e-consults to just other things too. You know, I would look at the physician notes. If there's anything you can get from the patients, it seems like that would be also very helpful to identify dementia. I think I would just think about like use cases of how is the information that you're getting from the e-consults, the patient notes, or from patient provided information, how is that going to lead you to getting a dementia diagnosis? Like, what is the logic model for that?
Yes, I concur, and I would say that we have no choice but to extend that beyond the walls of the hospitals, because you have the Reddit and Twitter and open data that are applicable and are having the health determinants, the community concerns and so forth that could be used as a test bed for NLP.
Wonderful. Thank you both. And John.
In defense of family medicine physicians everywhere, you don't consult someone for a trivial question. we answer those. We always send the consults, the consults are the complicated ones, right? Sorry, you've mentioned about the dermatology. We had one of those where somebody invented a dermatology consult service and they were using it all over and they wanted to deploy it in family medicine, and it's like, no, if it's bad, we want to just send them right to the dermatologist. We don't need a computer to do the interface. But what I want to ask you in terms of this particular work is, it sounds like you're going to be mostly working with the text that is typed into this console. And I think that there is evidence in various people who've looked at it that our own biases, unconscious or maybe conscious, will come into the words we use in the notes. And so I'm interested to know your thoughts on how to, know when that might be impacting your model, or how you might try to detect biases like that are going to be just in the words we use to communicate with each other because of our unconscious bias.
Absolutely. If I was talking on behalf of AI, it had talk, and I would say back, thank you very much. You always want me to do predictions for you, but you give me your own training material, which is full of biases, and then you accuse me of being biased.
Yeah.
So as part of the explainability is an absolute valid concern, the bias. So the machine doesn't know that it doesn't know. I think that's an area of machine learning in general to pursue, and maybe next level. But human does. And I think we always overlay other data to see whether, for example, the gender had something to do with the dementia predictions, or the data was imbalanced in that sense, that we had more female or versus male, or that of the overlay of the LTC dementia patients, so that we can detect the bias. But I think the pursuit of bias and detection is more important than the bias itself, and we are on that path for sure.
Wonderful. Thank you so much, Arya.
My pleasure.
Everyone join me in warm congratulations to Arya as well.